Good morning, everyone. On behalf of the National Collaborating Center for Indigenous Health, I welcome each of you to today's webinar, Visioning the Future Public Health Series, Governance and Data. For those of you who weren't able to join our April 8th webinar on determinants of health, the Visioning the Future webinar series is a series of webinars presenting a vision for First Nations, Inuit, and Métis Peoples public health. These webinars are a development of the NCCIH's 2021 publication, Visioning the Future, a collaborative report offering a vision for Indigenous peoples' health and well-being. Privileging Indigenous knowledges, the commissioned report complements the Chief Public Health Officer's 2021 Public Health Vision Report entitled A Vision to Transform Canada's Public Health System. Today is the series' second webinar. My name is Dr. Julie Sutherland, and I'm a research associate with the National Collaborating Center for Indigenous Health. Our center is located at the University of Northern British Columbia in Prince George, BC, the traditional territory of the Clé-Clé-Dene First Nation. I am, however, zooming in from Moncton, New Brunswick, on the traditional unceded territory of the Mi'kmaq peoples, and I will be facilitating today's webinar. Very briefly, the NCCIH is one of 6 national collaborating centers for public health that was established in 2005 with funding from the Public Health Agency of Canada. Our sister NCCs are focused on specific topics, including infectious diseases, environmental health, healthy public policy, determinants of health, and methods and tools for knowledge translation. Our center supports equity for First Nations, Inuit, and Métis peoples by promoting the use of Indigenous-informed evidence to transform practice, policy, and program decision-making across all sectors of public health. Just a very few housekeeping points here for this Zoom webinar. All questions for panelists as well as technical questions can be submitted in the Q&A window, and we encourage you to ask your questions as you think of them rather than to wait till the end when we're actually going to host the Q&A. So feel free to pop those questions in at any point. Technical questions we'll answer as quickly as we can, and the other ones we'll save for the end of the webinar this morning. Links to resources mentioned will be posted in the chat window, and today's session is being recorded and will be available on the NCCIH website. Just to know that there may be brief pauses as we switch between presenters, so stick with us, bear with us, and we'll make sure to get you both of those presenters as quickly as we can. A few learning objectives to share with you, and these are objectives that we've set for the whole series on Visioning the Future. These objectives are to examine current inequities in mental and physical health among First Nations, Inuit, and Métis populations, to consider the social, political, and historical contexts that have been the fundamental drivers of these inequities, to understand how reestablishing Indigenous peoples' health systems and ways of knowing and being are vital to overturning these inequities, to explore practical strategies for achieving health equity. Information about remaining webinars, and we're still planning 2 more in this series, will be available soon. The best way to get information about those is to join our mailing list. You'll see the URL on the slide that is being shared right now, and we'll share that information again at the end of today's webinar. And now to the real thing, today's presentation. Today's presenters will show how Indigenous peoples' ownership and control of their past, present, and future are critical elements of their individual and collective health and well-being. We are honored to have 2 presenters for today's session, Dr. Danièle Behn Smith and Dr. Shannon McDonald. Each presenter will speak for approximately 15 minutes, and we will hold a Q&A session at the very end after both speakers have presented. Our first speaker today is Dr. Danièle Smith, and it's my honor to introduce her. Dr. Behn Smith is Etcho-Dene of the Fort Nelson First Nation in British Columbia, with French-Canadian Métis roots in the Red River Valley. As Deputy Provincial Health Officer, Indigenous Health, Province of British Columbia, she works alongside Dr. Bonnie Henry, Provincial Health Officer for the province. Dr. Behn Smith provides independent advice and support to the Ministry of Health on Indigenous health issues. In support of the ministry's strategic agenda, Dr. Behn Smith works in meaningful partnership with Indigenous collectives, communities, and organizations to advance wellness and disrupt colonial practices and policies. Today, Dr. Behn Smith will reflect on the importance of a paradigm shift away from conventional population health data about Indigenous peoples. She will examine how disaggregated data that is self-created and self-governed can inform actions that will achieve health equity. Dr. Behn Smith, thank you so much for joining us today.
Masicho, Marcy, Tanshe, Kiawao, Doani. I'm wondering if you're seeing my screen.
We are seeing it. Thank you so much.
Okay, wonderful. Perfect. Tanshe, Kiawao, Doani, Danièle, Behn Smith, Dishnakashan, and Michif, Pi Echodene Nia, Sezitla, Danièle, Behn Smith, Ate. Winnipeg, Treaty 1 Doschen, Fort Nelson, Gotse, Ate. Ma paranti kayas osche la rivière rouge ki ostravak, ni muiten ne ikaskitek. Good day, everybody. It's wonderful to be with you this morning or this afternoon for those that are joining on other parts of Turtle Island. It's really a pleasure to be able to introduce myself in my languages. I've just recently started to learn Southern Michif and Dene Slavey, and I want to publicly thank my language teachers, Heather Souder from Camperville, Manitoba, and Curtis Dickey from Fort Nelson First Nation. It's been tricky, and I don't typically get nervous really when I'm doing public speaking, but when I'm introducing myself in my languages, I get sweaty palms. So thanks everybody for giving me this opportunity to work through that. I'm very grateful to be joining you today from the territories of the Lekwungen peoples of the Songhees and Esquimalt nations. And I acknowledge all the ancestors, descendants, and all of the medicines that are in these waters and lands. Also, this beautiful artwork by Christy Belcourt, and I'm going to speak to it a little bit more in a moment. And to begin, I just want to raise my hands in extreme gratitude to the total powerhouse and leader in the area of Indigenous data sovereignty that is Gwen Phillips. The grandmother's perspective, this quote, First Nations governments are not wanting to operate with the big brother mentality that we've all been groomed into believing in relation to what data does to us. It's more like we want to come from the grandmother perspective. We need to know because we care. This quote was taken from the British Columbia Office of the Human Rights Commissioner's report on disaggregated data that was released earlier this year. And Gwen's quote really grounds us in the humanity of data. Data is us. It's our families, it's our communities, it's our stories. And it can help us track our progress towards that shared goal of vibrant, self-determining Indigenous individuals, communities, families, nations. In order for it to do that, I think that it's really helpful to talk about what are the things that we need to be well, what are our roots of wellness, and what are the things that continue to get in the way of us meeting our maximum wellness potential, and then how does data help us get to where we want to go. And so with that, I want to share with you this image from the First Nations Population Health and Wellness Agenda, which is a collaboration between First Nation Health Authority's Office of the Chief Medical Officer, my wonderful friend and colleague, Dr. Shannon McDonald, and our office. And so this image really illuminates the things that we need as First Nations peoples to be healthy, vibrant, and self-determining. And in my experience, I don't want to, put forward a pan-Indigenous approach, but in my own lived experience of working and receiving teachings from many different elders and knowledge keepers around the world, I think there are universal laws that are depicted here that apply to all. And so if we look at the deepest roots of this ecosystem, those are our deepest roots of wellness, the things that make us uniquely who we are as Dene, Tunaha, Michif, Anishinaabe. It's our culture, our language, our lands, our nations. And we need those in abundance in order to fully be ourselves. In the shallower soil, the shallower roots of wellness, what's represented there are the mainstream settler systems that we need to interact with in a good way to get our needs met. And so it's across the board. It's health, it's education, justice, child and family services. We need all of those settler systems to be free of racism and discrimination, to be culturally safe, and to be filled with individuals and actors who take up attributes and behaviors that are anti-racist and culturally humble. And when those roots of wellness, those deepest roots of wellness, our sovereignty, our self-determination, jurisdiction over our lands and laws, when the shallower roots of wellness, those systems are performing at a high level that is free of racism, then we flourish and we thrive across the life course. And we can be fully well and balanced in mind, body, and spirit, and in relation with all of our relations around us. And that's what's represented by this intergenerational family that's out on the land harvesting food and medicines with all their relations in a good way. So for me, this image really clearly visualizes the elements that we need in order to track our progress. And so to counter that, that pan-Indigenous way of approaching things, we actually need distinctions-based partnerships with nations who can further unpack and tell settler systems what indicators, what signals, what stories are most important and relevant to them across these three levels. So their deepest roots, their lands, their language, the settler systems that are operating on their territories, and then of course what being healthy in mind, body, and spirit means to them. That's really what's required in order to track our progress and track Indigenous population health data in a good way. So to speak to Christy's beautiful image a little bit more, when I think about who I am and the teachings that I've received, I do think about this beautiful artwork and quote from Christy Belcourt. So the piece is entitled "Our Lives Are in the Land," and the quote is that the plant are teachers. They are connected to each other and all other spiritual beings through the sacredness of life. When I remember who I am, a human being connected to all of life, I remember also that I'm loved by the spirit world and our ancestors. And when I remember this, I remember to respect even the smallest of things. This is who we are, and these are our deepest roots of wellness. And so my beliefs include that being healthy and well means being in harmony and balance in mind, body, and spirit with all of our relations, that humility, gratitude, respect, food, ceremony, land, laughter are all good medicines, and that self-determination is the key determinant of health. And in terms of tracking or establishing the context of a way forward in tracking Indigenous population health data, I believe that structural and systemic Canadian colonial practices and policies undermine and interfere with our ability to be healthy, vibrant, and self-determining because, oh, my apologies, my screen froze. Oh, I'm having some kind of difficulty. There we go. They interfere and they violently arrest our ability to be well because they are deeply rooted in ideologies of misogyny and white supremacy. And so it's so critical that we dissolve those barriers that still prevent us from tracking data in ways that are holistic, that daylight all of our roots of wellness, and uphold distinctions-based approaches. If anybody's seen me speak before, you've likely seen this painting because I put it up almost every time. This painting was created by Cree artist Kent Monkman, and it's called The Daddies, and it's a recreation of an original painting by Robert Harris called The Fathers of Confederation. Harris was commissioned by Ottawa to create a painting to honor the Charlottetown Conference, which was one of 3 conferences that ultimately led to the Confederacy of Canada. And the story that I've heard is that when Kent Monkman saw the original painting, in the foreground there was an empty footstool, which he has since occupied with his alter ego, Miss Chief Eagle Testicle. And he saw that empty footstool as an opportunity to draw attention to and comment on the absence and the deliberate exclusion of Indigenous peoples and women at this pivotal moment in Canadian history. We were excluded from this key event because of epistemological differences and the widely held belief that Western European ways of knowing and being were superior to that of Indigenous peoples. So there was an ideology of white supremacy, and in order to move forward in a good way, I find it personally really helpful to ground myself in these alternate truths. Christy Belcourt's image that reflects some of the worldview that is embodied by many Indigenous peoples around the world about our interconnectedness, and also the truth that white supremacy and misogyny are the bedrock of the structures and systems that govern our day-to-day lives. Last year, I had a chance to speak at the Orange Shirt Day event here on Lekwungen territories. And one of the things that I commented on was that, my heart felt good to feel really confident that there was nobody gathered in that square on that day that held that personal belief that non-Indigenous peoples were superior to Indigenous peoples. But in our everyday lives, in our settler constructed mainstream society, this belief is so deeply embedded that it continues to manifest as gross disparities in every indicator we count. So the work before us is to illuminate and arrest that white supremacy every single day. And one of the important ways we do that is being disciplined in our language, specifically around data. So being subjected to Canadian colonial practices and policies is bad for Indigenous people's health. Pretty much on any health outcome or determinant of health outcome you choose, status Indians fare worse. I'm using that language because that's the group that's represented here in these graphs. And I just want to, draw attention to the fact that when we are reporting health findings, typically in an epidemiological standard, epidemiology is really studying disease patterns and different exposure risks. So we say things like smokers are more likely to die than non-smokers. People who are unvaccinated are more likely to require critical care than people who are vaccinated. So, the risk exposure or the protective factor being vaccines, the risk exposure being smoking. When we look at these types of graphs, we say things like Indigenous students are less likely to graduate from high school than non-Indigenous students. And the problem is that we're conflating indigeneity and Indigenous identity with risk. The exposure that confers risk for us is the socially constructed reality and experience of being a status Indian or being subject to Canadian colonial practices and policies. And in fact, you know, the reality is that our indigeneity is what gives us strength and resilience. Those deepest roots of wellness, our lands, our language, our culture, those are protective factors, not risk factors. So there's another artist's painting that I use as a guide and a touchstone when I think about how to move forward. This painting is entitled Sharing Bioethics, and it's from Dene bioethicist Lisa Boyven. And so this image just reminds me many different things. One, that we need distinctions-based approaches because we need to see multiple worldviews. Settler systems need to vigilantly shrink themselves, de-emphasize themselves to create space for Indigenous worldviews. And we need to come together in relational ways to activate that intersection. In terms of how this image may be applied to Indigenous population health data, it reminds me, or reminds us, that data tell the stories of specific Indigenous peoples and nations, and they must be governed. That data needs to be governed by us. However, it also needs to be received by ready ears, hands, and hearts among the various actors in settler systems who embody cultural humility and who take actions in response to arrest white supremacy and racism in different spheres of influence. I notice I'm just going over my mark by just a couple minutes, Julie, but I'm almost done. So I'll just quickly finish with these last few slides.
Absolutely, thank you.
Okay, thanks. Indigenous population health data contributes to achieving our shared goal of vibrant, self-determining Indigenous peoples by making visible Indigenous peoples' many strengths and honoring our resilience. Put another way, Indigenous population health data accurately labels and measures risk factors that make us vulnerable: racism, dispossession from our lands, historical and contemporary fracturing of our families. And it also daylights and leads to actions that enable our protective factors to mitigate those risks. It also creates accountability within mainstream settler systems to arrest and disrupt structural and systemic racism. Indigenous population health data holds up a mirror for settler systems and decision makers, reflecting the systemic racism and social exclusion that continue to erode the roots of wellness of our peoples. And the grandmother perspective keeps us on course because it grounds us in the relationality of Indigenous population health data. When I think about Indigenous people's data, I think about this chart, which is from the Population Health and Wellness Agenda, and it's age standardized all-cause mortality rate from 2005 to 2017. This chart tries to count the losses in our families and communities over a period of a time. And for me, this one in particular is heavy because over a 14-month period that is captured in this chart, we lost 4 generations in our family. This photo was taken from my med school graduation, and I was so blessed that I had both my grandmothers with me on that day. My Etsu Mary Behn on the left in the purple, and my Mère Lucienne Zumen on the right in the colorful floral dress. In December of 2016, my Etsu Mary Behn, the matriarch of our family, died. And then in the following 13 months, her daughter, my Auntie Elaine, died, who's pictured here. Her grandson, Elaine's son, my cousin Ryan, died. And my Etsu's great-grandson, Elaine's grandson, Ryan's son, my cousin Warren, died. 2 of those deaths are counted in that previous graph. And obviously that graph is completely insufficient to capture our grief and to capture the devastating blow to cultural continuity that was losing 4 generations in one branch of our family. So that is why it is so important that our stories are never solely told with data and graphs, or numbers and graphs, but that they're told in holistic and diverse ways and within culturally safe spaces where we can come together collectively and take actions to make things right and honor those who have lost their lives far too early due to intergenerational trauma, racism, and white supremacy. So Masicho, Marcy, thank you for your time and attention this morning. Pishki Yimisho.
Dr. Behn Smith, thank you so much for making the humanity of data so evident for us. For somebody like myself with an educational background in languages and literature, I quite ignorantly think of data as just numbers and statistics. And you have made me poignantly aware of the fact that the line that stays with me is data is us, it is our stories, and that will stay with me. So thank you for so passionately and informatively sharing your knowledge with us. Our next speaker, and it is my privilege to introduce her, is Dr. Shannon McDonald. Dr. McDonald, proudly Métis Anishinaabe with deep roots in the Red River Valley of Manitoba, is Acting Chief Medical Officer at the First Nations Health Authority. Dr. McDonald is a trained physician with postgraduate medical training in community medicine and psychiatry, and has worked for over 25 years in the area of First Nations and Aboriginal health. Not possible. Dr. McDonald has extensive experience both in the federal and provincial government contexts. As an influential leader, Dr. McDonald was awarded BC's Physician Champions of Change Award by Doctors of BC for her leadership and advocacy for physician services in BC's rural and remote First Nations communities. Today, Dr. McDonald will highlight how external control of First Nations by central governments has contributed to a system of health services that is inappropriate, inadequate, and full of systemic biases. She will highlight the cruciality of First Nations health sovereignty to this population's health and well-being. Dr. McDonald, thank you so much for joining us today.
Thank you, Julie, and thank you, Danièle. When you cry, I cry. You got to stop doing that. And I kept flipping through the pages of my notes thinking, well, she's already said that. She's kind of said that. And so we work together all the time and think similarly. I'm calling in today from Silk's territory, where I am honored to be working for this week. And I want to honor and recognize the ancestors and the people that are still here who have had a relationship to this territory and these waters for such a long time immemorial. They have had their feet rooted here. My own story from the Métis Nation in Manitoba and the Anishinaabe people in Manitoba and Treaty 1 territory, that relationship between Indigenous and non-Indigenous people that had changed the absolute trajectory of my family, my history, my people. And it has really driven me to do work in a different way. So I'm going to take a little more of the historical perspective, just to review things you already know, but to be able to put them in the context of how are we developing in terms of a public health system that respects, honors, and supports self-determination by First Nations people around their health care service delivery. Could I have the next slide, please? Thank you. So I could lecture on this slide for like a whole day. And I will talk about each of these boxes a little bit in the presentation, but just recognizing that there were historical governance systems among First Nations people on this land long before settlers arrived. And the power differential between the settlers and the Indigenous people, for lots of different reasons that I'll talk about, created colonialism, patriarchy, misogyny, and absolutely in an immediate sense and over the long term has affected Indigenous health. We've had an ongoing conflict of structures, worldviews, ideas about decision-making and service delivery. Who has the right to make those decisions, and who has the right to evaluate those decisions? Where we've been working at the First Nations Health Authority in the last 13 years and before is that context of collaborative models of public health service delivery. It's new ground. We're evolving all the time, and we've seen things change significantly over my career from where things were when I first worked for Health Canada back in 2002 to where we are today. There's an absolute shift, but it's still not enough. And where we're trying to go is that model of Indigenous health governance. We'll talk a little bit about what that means. Could I have the next slide, please? So we moved to a subsequent collaborative model, but where did we start in terms of the relationship with settler populations? First Nations had an existing and many existing complex governance systems with full sets of laws and values. And with contact, settlers said, no, that's not real. That doesn't fit our model of worldview, our model of thinking. And they imposed that European system of government, which denied Indigenous rights and title and forced relocation. And so it took the people away from the resources that they needed to survive. And the settlers also brought infectious disease that decimated communities and led to the loss of systems, knowledge, and culture. We can't even begin to speak about residential school systems, about Indian hospitals, about the 60s scoop, and many other very deliberate genocidal practices that came with all of that. Colonization very deliberately aimed to destroy cultures and to force assimilation. They interrupted regular food harvesting, which meant food insecurity for remaining community members. And growing up in the Red River Valley, we know that that starvation caused people to go and work at Lower Fort Garry, at the forts all over the province, because that's where food and Western medicine, as it was at the time, were available. So it just pulled people more and more away from their traditional lands and their traditional ways. Next, please. So going back to the First Nations governance systems, some of us come from matriarchal communities. Some of us come from very strong clan-based communities. And those structures, those ways of understanding the world and developing laws and values that that's not the right word, that outline what acceptable behavior was and how we were to treat each other. But we did that with full jurisdiction on those traditional territories, that those systems of government had checks and balances within them so that everybody was taken care of. Nobody was left behind. But after the settlers' arrival and the colonial governance system was established, it removed First Nations from territories. The assimilation process disrupted those governance systems and destroyed culture deliberately again, changing food ways, changing ways of being able to gather and celebrate spiritual and cultural events that gathered people together so that there was a shared understanding of the world and a shared value. And the language was lost or eroded. And I'm so proud of Danièle for learning the language and spending the time to do that and sharing that with her children. It's so amazing. the specific and deliberate denial of Indigenous rights and title. And the treaties were not fair play, remembering that the context of communicable disease and starvation and pulling people from the land meant that the treaties were the only way people could survive. And the understanding of the people who were part of those treaty negotiations was very different from the settler populations in terms of the goals of those treaties and the decision to respect what was in them in a fulsome way over long periods of time. The racist assumptions of being less than, even not even fully human in some of the language in some of those early documents, created a detrimental service provision. So that's where Indian hospitals came in. That's where the transition from healthcare as part of economy. So if you go back to the Treaty 6 medicine chest clause, what was in there was the belief by the Indigenous people that the diseases brought by the settlers needed Western medicine to cure them. And so there was an assumption that they would receive those kinds of supports. That wasn't necessarily the meaning or understanding of the people who were signing the treaty from the other side. And there was a very specific decision about who received or didn't receive high quality healthcare. And the outcomes for First Nations people as a result of all that: poverty, isolation, starvation, infectious diseases, and decimated communities. And what's really frightening, and what Danièle has brought forward in terms of how are we measuring things, all of those deficits, all of those tragedies were the things that were most spoken of, most measured, and most supportive of the racist assumptions that the settler population brought. Next slide, please. So over time, First Nations in Canada were forced for their basic needs to interact daily with the systems and structures that were built specifically to support the racist colonial values and biases. So it impacted health, education, justice. All of those systems were built and structured and continue to be structured based on those pieces of thought. And they are all structured on those deficit models versus a reflection of the actual resilience of the Indigenous people against all of these odds. That was never a part of what was being observed. In fact, resilience was perceived as a threat, and many communities received direction from governments that the communities were to be split into different communities, or children were to be taken away so they weren't influenced by that resistance. So we know that treaty arrangements and service arrangements and the fish on the hook was money. And it was always there, that those treaty arrangements and service arrangements are all attached to, you need it, we've got it, what are you going to do to get it? And they all fail to recognize community capacity and diversity. That pan-Canadian view of Indigenous people is so harmful because every community is different. But the assumption of colonial society is that we are all the same. We have the same needs, and those are needs that are defined by the colonial. The COVID-19 pandemic is an example where First Nations got really involved in public health decisions, but many of those decisions were without the full participation of First Nations people. And we have really struggled in our evaluation of the work that we did to be honest about how much of a voice Indigenous people had. In the last week, I've been with communities, leaders, and health providers from the communities in the interior region here in BC. And when we talked about COVID, the most common thing that we talked about in terms of impacts of COVID in community were not only the losses, as Danièle brought forward, but the inability because of the rules to respond to those losses in a way that is done traditionally. The ceremonies, the gathering of people to support a family in mourning, those things were not possible in the context of COVID. And there has been a huge gap in the spiritual understanding of people about the comment that Christy Belcourt makes about coming from the land and returning to the land. And one of the elders I've worked with in my life has told me that I am made up of the dust of my ancestors, that the land that I come from, the land that created me, is the land that holds those ancestors, and I would not exist without them. So when we talk about those things in terms of public health decisions, it is not something that's well understood by many of our public health colleagues. Next, please. Thank you. So, self-determination, what does that really mean? I had a whole bunch of children, and I remember very strongly when they came to the age 2, 3, 4 of self-determination, when they kind of looked at me and said, nope, that ain't gonna happen. We need to negotiate around it. And one of them actually became a lawyer. Somehow that didn't surprise me. But when we talk about our relationship with the Canadian healthcare system, there is a real sense of Indigenous people as children in the Canadian system, that we still need to be controlled. We still need to be protected in a way that isn't ours to decide about. So those treaty service arrangements and external controls by central governments do not recognize community capacity and diversity among First Nations people. That childlike treatment really makes it difficult for communities to express those needs. The chart there, or the picture that Danièle showed about, what do we need to be healthy? Well, there's a huge conflict between the health service for First Nations people that exist right now that are inadequate, inappropriate, and systemically biased. But to be honest, often well-intentioned, because those core beliefs about the capacity of First Nations people are still so strongly held that as communities try to assert self-determination, there's a real conflict in worldview. I am blessed in the work I get to do in a First Nations-led healthcare system that is continuing to evolve by First Nations, for First Nations, and the examples that are here are First Nations Health Authority and the First Nations Information Governance Council, I believe is FNIGC, where people have come forward and said, no, there has to be a different way of moving forward. We have to be able to assert our needs and values and our solutions based on those strengths and our capacities. Next, please. So I'm often in conversations about BC First Nations public health vision for governance, and that is the realization of First Nations health sovereignty. And probably the most common conversation I've been having over the last while has to do with data. Who decides what gets measured? How do we measure it? We have the First Nations client file in BC, which is a combination of vital statistics, the Federal Indian Registry, the Provincial Registration and Premium Billing client file. And when we bring all that together, we identify all of the status, only status, First Nations individuals and those who are eligible for status. And we use that to link it to provincial health systems. So somebody else controls that First Nations client file. Right now it lives at the Ministry of Health. And we have a process to support data linkages that hopefully answer some of the questions we need to do public health planning, but it is still not information that is held by community. The information is not prioritized by community, and how that information is shared with community is very limited. It is aggregate data only. It is by the choice of what the province or other healthcare organization is willing to release for those linkages. And the interpretation of the data is challenging, as Danièle has brought forward. Next, please. So one of the things I think that has come forward very strongly, and there's another document that Danièle and I worked on together, the Sacred and Strong Report. It's Women's Health, Indigenous Women's Health Report in BC. And one of the things that we worked very, very hard on was to include the voice of the people, not just data. When we look at this collaborative model of public health service delivery, strong and shared governance, working to reclaim First Nations health sovereignty, but we're not there yet. We're evolving towards that. But having that local access to data, having full transparency as much as we can while still protecting individual privacy, looking at a community-driven and nation-based approach, two-eyed seeing, so bringing my medical education and my experience in the Western academic world and bringing that to the Indigenous worldview and the Indigenous way of thinking to develop meaningful partnerships within the health system. And the really important concept that's often hidden in our documents is that of reciprocal accountability, that nothing about us without us. And that's something that has been developing slowly, and I think we're definitely making progress. But the other piece of that is really about cultural humility. As a Western system of care, as ministries of health, as regional health authorities, as hospital-based healthcare systems, we need to develop a different level of cultural humility and know and understand that what we believe to be necessary and right come from that racist structural process that's been embedded in Canadian culture. And so that reciprocal accountability really requires that cultural humility. Next slide, please. So what we do know from the work that we've done is that outcomes are greatly enhanced when First Nations are directly and equitably involved in public health responses. Full and transparent access to First Nations specific data has been an area of contention, and we are working very hard with communities, with nations, with families, with systems to make that a different place. We must utilize that two-eyed seeing and bringing all of those pieces and the marshals who brought two-eyed seeing as a concept to us. It's so, so important to approach that two-eyed seeing in planning and implementation of public health actions that things are not going to be done for First Nations as we move forward, but rather done with. And I look forward to that day post-retirement to be able to look back and see this continue to progress, and that the voices of First Nations people are front and center in terms of building capacity, doing the work, and making a difference in terms of health status for First Nations and Indigenous people. Thank you.
Dr. McDonald, thank you so much. I was particularly struck by when you were speaking about First Nations governance systems, the line, everybody taken care of, no one left behind. And thank you so much for discussing ways that we can get back to that that dream that can become a reality. Thank you so much. We have about 11 minutes for Q&A. I see that some are coming into the Q&A section. Please continue to post your questions there. Just while we're waiting for those to build up, I'd like to say a quick thanks, in addition, of course, to Dr. Behn Smith and Dr. McDonald. A special thanks to all the people working in the background. If I seem even remotely calm, it's because there's a team back there making things run smoothly. So I'd like to just thank specifically Roberta Stout, Zishan Kadar, and Donna Atkinson for their help today. So let me just take a peek here in the Q&A. We'll just go from the top, and this is a question for both speakers. So perhaps Dr. Behn Smith, if you could tackle it, and then perhaps Dr. McDonald could add to it. Please elaborate on what distinctions-based means to you, and what brilliant future of data we can work towards using these distinctions. There's a lot there. Dr. Behn Smith?
Yeah, and thank you. And thank you acknowledging this is from Carla Helgeson, a friend and a colleague. So I see she's putting us on the spot with some tough questions, but no, you know, at its basic kind of conceptualization, I think distinctions-based was really pushing the government to not just have a pan-Indigenous approach to relationships with Indigenous governments, and recognize that there are First Nations, Inuit, and Métis as three distinct groups that are recognized under the Constitution. I would say, however, that distinctions-based approaches to me now means that that it's about coming to that circle, those two circles, and recognizing that whoever is in that circle across from you is a distinct individual who comes from a distinct family, distinct community and nations, and has a distinct lived experience. So for me, it's really, you know, adding all of these layers to what that means. And during our language class on Wednesday, my daughter asked our language teacher, Curtis, she said, well, I've been using this South Slavey app, and I don't know, is that okay? Like, are those the same words? And he said, you know, our language is so endangered that we need to pick up any kind of words. But he said, yes, it's a different language. And he said, if you take the folks who live in Prophet River, or the people that live upriver and downriver from us, we speak differently. So even like in 100, 200 kilometers, we're the same, you know, language group, family group, but we're distinct. So I think from my perspective, Carla, I'm still learning really what it is, distinctions-based approaches, but I'm starting to understand that it's very, very distinct. Like we can take it down to that individual level. I'll pass it to Shannon.
Yeah, I'm just reading Carla's second question there about what do you foresee as the balance being when proceeding in a distinctions-based way, ensuring colonially displaced Indigenous peoples have a role. This is part of the evolution that First Nations Health Authority has struggled with, because traditionally the federal government only provided what limited services there was to First Nations people, status First Nations people who resided on reserve. And over time, the Indian Act and other processes were actually eroding the population that qualified for the services that they provided. We have worked really hard in terms of identifying our responsibility for urban populations. For example, in BC, over 60% of Indigenous people live in urban settings, and people like me who have backgrounds on both Métis and Anishinaabe world, but I'm not status, but I live on a reserve. I mess people's heads up because those things just don't fit in the boxes that have been created. So I think over time we will see those boxes, those lines erode as Indigenous people take control more and more and start saying, our family is defined the way we define it, not the way a federal government defines it. Our community is who we define as a member of our community, and hopefully we will move forward on that. And hi, Carla. Long time no see.
I'm sure she's waving back. You just can't see it. Skipping, thank you to you both. just skipping down to the bottom of the next question, as Bill C-31 erodes Indigenous peoples, what are we doing about the Indian Act and its ongoing assimilation and depopulation of Indigenous nations in Canada? Maybe just very quickly, if you could first summarize Bill C-31 in one line, and then respond to that. I'm not sure.
Oh, wow.
No pressure. But just for those who might not know what Bill C-31 is.
Right. So under the Indian Act, the old rules, which are still the new rules, but we're working on that, said that especially for women, misogyny strikes its head. If you married outside of status First Nations family, then you lost your status, as did your children. That's basically the core of that. There were other reasons why people could lose their status: military involvement, or going to university, for example, would be enough to have people lose their status. Bill C-31 was the first of what I assume will be several attempts to eradicate those rules and to welcome back family members who had lost their status as a result of the rules of the Indian Act. We're not done yet. This is going to go on for a long period of time, and I know lots of people who have done genealogy work, who have tried to gather information to establish themselves as status First Nations people, but it is always on the back of the individual to do that work. And I think we need to push forward and say it shouldn't be individual responsibility. There should be support for families, communities, and individuals to confirm who they are by their definition, not by the definitions of the Indian Act.
Thank you so much. Dr. Behn Smith, do you have anything to add?
I guess what I want to add is, just that who we truly are, and our roots and our indigeneity. And I received such a wonderful teaching from a Navajo elder, Harry Walters, in Arizona. And I was struggling with this idea of having to work in different worlds, having First Nations, Métis ancestry, and working in a biomedical world. And he could see that I was really struggling with this. And he just looked at me and he said, "My girl, it's just in you." He said, "These are the same moon and stars that your grandmother, great-grandmother, great-great-grandmothers prayed to." And so I think sometimes I know that the Indian Act and the bills that have been passed to try and make it somehow more just create this haze and fog that keeps us from who we truly are. And there is no card, there is nothing that the government of Canada grants me to make me who I am. I from the very first moment that I took, that breath, I was who I am, and I was connected to my ancestors. And so at the same time, I don't want to dismiss the importance of that legal tool and the ability to have that status, to hold the government to account, to uphold treaty obligations. For example, I am a Treaty 8 member descendant. So it's just complicated, but I just never want to lose sight of that. And for people that are listening, for people that are exploring or learning about their connections, it's just a part of who we are, and there's no plastic card that makes us more or less Indigenous.
Thank you for adding that. It's just in you. What a lovely teaching, something to carry with you for sure, with us all. I'm afraid that we are coming to the end of our time for Q&A, but I do want to let everybody know, a couple of people have asked whether the links that have been shared in the chat will be shared later on, and they will not be available later on. So please copy and paste them before we exit today, if you want to keep those links. Roberta, if you could just share the suggested resources screen while we wrap up. And while I'm waiting for that screen to be shared, I'd like to thank both Dr. McDonald and Dr. Behn Smith once again for being so knowledgeable and also so passionate and engaging. Thank you very much. just a couple of suggested resources here that we will share again. You'll be able to see these resources when the recording is available on our NCCIH website. And for information about upcoming events, including the remaining 2 webinars in this series, you are invited to join our mailing list, which is here on this screen. You've got a URL that you can go to, or you can scan the QR code from the screen. Technology continues to amaze me. So we're at the end of our time, and I have taken personally so much from both of your talks, and I know that our participants have done the same. We had more deep and profound thanks in the Q&A even than questions, and I'm sorry that we couldn't get to all the questions today. Thank you to our guests for attending. Thank you to our presenters, and I wish everyone a good afternoon. Thank you.